Muchas gracias por la amable invitación a su gran conferencia.
Let's focus in on limbal stem cell techniques. I have no relevant financial disclosures, so let's talk about partial limbal stem cell deficiency first. In partial limbal stem cell deficiency, if the visual axis is not affected, topical lubrication alone suffices. However, if the visual axis is affected, then the next aspect is your adnexal affected or not? If it is affected, go ahead and correct that abnormality. But if not, and there is fibrovascular pannus, you can consider doing the sequential sector conjunctival epitheliectomy with or without amniotic membrane. That is one option, or stem cell therapy. Now, if you don't have fibrovascular pannus and your adnexa is not affected, then you can just proceed with the procedure. Total limbal stem cell deficiency, you are faced with the same questions in the beginning. Is your axis affected? No, topical lubrication suffices. If your adnexa is affected, then correction of the abnormality is of utmost importance because your limbal stem cell transplant would otherwise fail. If it is not affected, your question is unilateral or bilateral. So in unilateral, what are our options for stem cell therapies? If autologous from the self alone, you have conjunctival limbal autograft, SLET, CLET, COMET, and allogenic options from other sources besides the self would be allogenic CLET, living-related conjunctival limbal autograft, or cadaveric KL-AL. So when you have bilateral limbal stem cell deficiency, the first focus should be your ocular surface. Is it dry? If it's dry, or if there are other issues such as a cost issue, or if there is systemic immunosuppression issues where patients cannot tolerate immunosuppression, keratoprosthesis may be a valid and the ideal procedure of choice. However, if your ocular surface is wet, you have the choice of a K-Pro or stem cell therapies. Now, how is it different? Well, not much, except for the fact that you don't have conjunctival limbal autograft, as mentioned in bold, and SLET and CLET are options. COMET is an option. However, SLET, currently the studies are rare in terms of bilateral. If we are doing bilateral SLET, then immunosuppression is of the utmost importance. So let's go through it step by step. I'm going to go through the 9 major procedures, starting from the autologous limbal stem cell techniques. The first one being conjunctival limbal autograft, which is surgically harvest of the conjunctiva and limbal tissue from the contralateral eye. You have between 2 to 4 strips that you use from the superior and inferior donor limbus. And there is direct transfer into the recipient eye. So the bonus here is you have one procedure. The limitation, however, is that it's for unilateral limbal stem cell deficiency. There is the risk to the donor eye, and live donor is what is necessary, so you can only take a part of the limbus. And if this procedure does fail, then you cannot go back to the contralateral eye. You would have to consider other options. What about autologous clet? Well, in clet, cultivated limbal epithelial transplantation, you have harvest of limbal stem cells from the contralateral eye. There's ex vivo expansion into limbal epithelial cell sheets. And so it makes this a staged procedure, which can be very tedious. There is the risk, though minimal, to the donor eye. It requires the presence of the healthy donor and preserved limbus. And with ex vivo stem cell expansion, you're dealing with all kinds of potential problems, including that it can fail. You can get a poor biopsy. It's time consuming and it's expensive. So SLET, which combines CLAU and CLET, there's a harvest of limbal stem cells from the contralateral eye, and there's direct transfer of the limbal stem cells into the recipient eye. So it's one-staged, it's cost-effective. There is the risk to the donor eye, but minimum, and it's primarily been studied in unilateral disease. COMET, cultivated oral mucosa epithelial transplantation is harvest from your oral mucosa. Here we have ex vivo expansion of the epithelial stem cell sheets. It's a staged procedure and it's cumbersome. You do have the benefit of those additional cells in cases where you have bilateral disease, but the same issues apply. It can fail, it's time consuming and expensive. So as of 2020, there has been a rabbit model on simple oral mucosal epithelial transplantation, direct transfer from the oral mucosa onto the ocular surface, which has shown good results, but yet we don't know much. Time is yet to show as to whether or not that would be efficacious for us in humans. So how do we go about cultivating corneal epithelial stem cells? Well, before we used to have the 3T3 fibroblasts, but now we have amniotic membrane. 2 by 2 millimeters of conjunctival epithelium is dissected from the area and transported into the lab into human corneal epithelium medium. In the lab, donor limbal tissue is shredded into small bits, and a 3 by 4 millimeter amniotic membrane sheet is de-epithelialized, and bits of limbal tissue is explanted over it, basement membrane side up. It's incubated at 37 degrees with 5% CO2 and 95% air, and cultures come in about 10 to 14 days, 2 to 3 weeks is when you would get about 2 to 3 centimeters in diameter for then transplantation. So what about our allogenic limbal stem cell transplant techniques? There's 3 major ones and then the 2 combination ones that we should know about. So with allogenic Clet, we have ex vivo expansion of limbal stem cell into the limbal epithelial cell sheet. It's for unilateral or bilateral disease because it's coming from another donor, which is either living or cadaveric. And the benefit here is that it's single procedure. Limitations, of course, with any allogenic procedure, just seal it, is immunosuppression is required. Living-related conjunctival limbal allograft, similar to the CLAU technique, technically, surgically. It's for unilateral or bilateral disease, okay? Living-related donor as compared to your KLAL, which is cadaveric. The donor and recipient immunologic matching based on blood type and antigens is of key importance. The tissue is fresher than KLAL, and similar issues remain with immunosuppression, risk to the donor, live donors, so you can only take part of it. And so if it fails, then another alternative has to be found. With KLAL, you have the option, because it's cadaveric, to use the 360-degree ring consisting of the entire donor eye cell. Those cells, because they're cadaveric, they're not as fresh, and so that can be of consequence to the outcomes in these situations. Tissues tend to not be immunocompatible, and there tends to be a high risk of rejection and failure rate over 5 years. With the Cincinnati procedure, living-related conjunctival limbal allograft plus KLAL, the living donor tissue is a relative. Severe unilateral or bilateral disease, living donor tissue, okay, is for your 6 o'clock and your 12 o'clock meridians, whereas your cadaveric tissue is sutured on to your 3 o'clock and 9 o'clock meridians. The limitations here combine the disadvantages of both. So you have the immunosuppression risk, you have the risk to the patient, the living donor's ocular surface. If it fails, another option has to be found. And KLAL, you have the issues of graft rejection and immunocompatibility. So the modified Cincinnati procedure is excellent. CLAU, which is contralateral plus KLAL. So the living donor tissue is from yourself. It doesn't have the immunocompatibility issues. Severe unilateral disease is its indication. And living donor tissue and cadaveric are sutured in a similar fashion as the Cincinnati procedure. The procedure cannot be repeated if it fails, okay? You have the risk to the other eye. Immunosuppression is required because you do have KLAL as part of this.